All the society members present here requested you to just put a reminder in your society groups, please. So people may join in. Please put in a reminder in your society groups.
It is now live, ma'am.
All right. So you may start the session.
Yes. I am sharing the slides. First of all, very good evening to all the faculties and delegates present over here. On the behalf of Corona Remedies, I am Tirth Shah. Welcome you all for the Happy Learning Masterclass webinar series, 190th edition, in association with Akola, Baramati, Buldana, Deoli, Savangi, and Pusat. I welcome Dr. Asha Jain, convener of the today's webinar. Dr. Asha Jain is the past president of Raipur Obs and Gynec Society, and she has a 32 years of experience. She has a Foxy Recognition Center of Ultrasound Training, colposcopy training, and currently she is the director of SMS Hospital Raipur, medical director of Cancer Prevention and Relief Society, elected member of Chhattisgarh Medical Council. She is a vice president of IMA Chhattisgarh. Dr. Asha Jain is a chairman of Mission Pink Health, IMA Raipur, and she is a executive member of ISCCB. Past operations of Dr. Asha Jain is she is a past secretary of IMA Raipur and past president of Rotary Club of Raipur North. And academically, she has a certificate course in FCCS and obstetrics, and she has a IOTA certification from IOTA Group, certificate of competence from the Gynec Academy in Gynec Ultrasound, Fetal Medicine, and Obs and USG. FMF UK certified for anti-first. Academically, she is training in colposcopy from AV School of Colposcopy, Chennai. And the field of interest of Dr. Sajin is the saving the uterus, fetal medicine, obs and gynec ultrasound, critical care, and preventive oncology and colposcopy. I think slides are visible.
Yes, they are visible.
Is it visible?
Thank you. Yes, thank you.
Okay. So, as per our tradition, before we start our discussion and go into the direct session, as per tradition, I welcome all of you to join the lamp lightning session. Please join the lightning session virtually. Now I am hand over this session to Dr. Asha Jain. Ma'am, over to you.
Thank you, Tirth. So, namaskar, everyone. I would like to welcome Dr. MC Patel, sir, whose brainchild is this program.
No voice, madam. No voice.
I think there is a voice. Everyone else can hear?
Yes, ma'am. It is audible.
Ma'am, Pranita ma'am, you just log out and log in again because everybody else can hear and I can also hear you.
No voice, madam.
There
Tirth,
could
will
be
you
some
please take
local
over?
problem because everybody can listen.
Check your volume first of all.
Ah.
If it is not working, then log out and log
She
in.
can't hear us. That is the whole problem. She can't hear any of us.
Yeah, that's what I'm saying. The volume is very low also. She can't hear, no?
So I think I'll give her a call. I'll just introduce her and I'll give her a call. So, namaskar. I welcome all of you to this 190th edition of Happy Learning Masterclass. This is the brainchild of Dr. MC Patel, sir. He has been doing it consistently for the last 3 years. And he has covered a gamut of topics where gynecologists can be involved in medical legal problems. So I invite Dr. MC Patel, sir, for the official welcome address.
Thank you, Dr. Asha, for kind words. So it gives me immense pleasure to welcome you all on 190th episode of Happy Learning Masterclass web series. And today joining society Akola, Baramati, Buldana, Devli Sawangi and Pusad. I welcome Dr. Sindhu Bhute madam. She has kindly consented to be guest of honor to bless the webinar. She is always with us in any of our academic activity. So welcome madam and thanks for sparing time for us to bless the webinar. I also welcome Dr. Aparna Burkar madam from Akola. She has also kindly consented to be guest of honor. Welcome madam. I also welcome Dr. Sunil Shah from Baramati. He has also kindly consented to be guest of honor. And Dr. Ajay Rai from Chikhli. He has also kindly consented to be guest of honor to bless the webinar. I also welcome today's learned speaker, Dr. Nithika Raghuvanshi from Akola. She is going to discuss very important topic related to abruptio placentae. And to chair that very session, I invite three learned chairpersons, Dr. Surekha Taide from Devli Sawangi, Dr. Sital Bhandari madam from Pusad, and Dr. Rajesh Kokre from Baramati. And today, as far as panel is concerned, it is reverse panel. Panelists will be asking question, and being a moderator, I will be answering. And we have selected topic of MTP Act and its amendment and what gynecologists should know. On first instance, it seems that MTP Act is a very simple act, but even today, there are so many friends, they have confusion as far as its provision is concerned. Just day before only, I was watching in one of the group, and there was discussion going on, and everybody were putting their inputs related to this MTP Act and some situation related that in that very situation, whether MTP can be done, and if at all can be done, then how? And you won't believe, not a single member was giving inputs in a right way. All the inputs were their own thinking. It was not at all consistent with MTP Act and its amendment. So in today's scenario, as far as our day-to-day practice is concerned, this act is very well to be understood. Otherwise, we may invite problem that we will discuss at the time of panel also. So for that, I welcome all the learned panelists, Dr. Dipali Shukla from Akola, Dr. Aishwarya Paradkar from Akola, Dr. Salaka again from Akola, Dr. Meena Agarwal madam from Pusad, Dr. Lata Agarwal madam from Pusad, Dr. Deepika madam from Devli Sawangi, Dr. Megha Karnik madam from Devli Sawangi, Dr. Pranita madam from Pusad, Dr. Jaya Tulaskar madam from Pusad, Dr. Sashi Bhopi madam from Pusad, Dr. Varsha Gate from Akola, and Dr. Sujata Nalat from Akola. I also welcome Dr. Asha Jain. She is convener in this series since long, and she is very hardworking lady. You will appreciate, because whomsoever he has contacted for this webinar, you will appreciate her efforts as far as webinars are concerned. I also welcome two learned coordinator, Dr. Rekha Rajendra Kumar, President Bengaluru. She is also in this series since long, and Dr. Monica Umardan from Solapur. Monica is always there whenever we are doing any webinar in Maharashtra, and she puts lots of efforts, and even for today's webinar also, she has helped me a lot, not only for this education, preparing this webinar, but for execution of this webinar also. So I put it in record my special thanks to Dr. Monica Umardan, and welcome Monica for this webinar. I also welcome all the learned president and secretary of joining society, that is Akola, Baramati, Buldana, Devli Sawangi and Pusad, and all the delegates who have joined this webinar. As far as this webinar is concerned, in era of COVID, when I started this series with three friends, now I am happy to announce it has reached 7,000 plus member family as far as Happy Learning Masterclass is concerned. Every time we go with discussion with a very focused topic, which are useful in our day-to-day practice, and one medico-legal issue which is also pertaining to our practice, and how we may end up into that problem, and how to get rid of this is the motto of this discussion as far as panel is concerned. So without wasting much of your time, welcome you all again. Thank you very much.
Thank you, sir. So I would like to have the CV of Dr. Rekha and Monica before we start with the official inauguration session. Tirth, may I have their CVs, please?
Yes, ma'am.
Yeah, next slide, please. So we have Dr. Monica Umbardan from Solapur. She must be very, very well known. She is the National Coordinator for Public Awareness Committee, a very, very active officer. And we have Dr. Rekha Rajendra Kumar ma'am, who is the president of Bangalore Obstetric Gynec Society, one of the largest societies of India. And she has another 32 years of practice, has many awards, felicitations. She is an IVF person, and she's a very learned and talented doctor, a great dancer. So welcome, Rekha ma'am. Welcome, Dr. Monica. Now, I request for the CV of Dr. Sindhu Bhute ma'am, who's our guest of honor. So, Sindhu Bhute ma'am has worked as a gynecologist for 52 years in different capacities in government and private institutions. She is presently working as professor in DMIMS Savangi. She's performed more than 10,000 laparoscopies, received many awards in national programs and hospital administration, and she is a life member of AMWN, NARCHI, etc., as she's also a UG and PG teacher. So this is a classic understatement of her CV. Welcome you, ma'am. Over to you for your words of blessing. We are really happy to have you with us.
Can you hear me? Or
Yes, ma'am.
Yes, ma'am.
okay. Good evening, all. It gives me great pleasure to be invited by Dr. MC Patel and his team. I am really thankful to Dr. MC Patel for I could not refuse him because of my problems, which I had so many problems, but still we could definitely I could attend this program. I wish my all. I wish the success in your 198th masterclass webinar, and you have selected a right person, Dr. MC Patel, who is program director also. And the topics are very important, and of course they are very interesting also. This abruptio placentae and MTP Act and its amendment is really necessary. Of the today's necessity is the MTP Act and its amendment, because in olden days, when this law was implemented, it was only one person's one practitioner's consent was necessary. Up to 12 weeks and up to 20 weeks, the two practitioners' consent is required. But now it is because the fetal anomalies are more. Definitely, this government has increased the gestational age of MTP, that is from 20 to 24 weeks and 24 weeks onwards. Of course, the medical board consent should be obtained. I am really thankful to you all, specifically the convener of today's function, that is today's webinar, that is Dr. Asha Jain, then two coordinators. I do not know I do not want to disclose the names because so many names are there and you have heard all the names from Dr. MC Patel. I really again thank to all the participants of this and of this seminar, and I wish all the success in MC Patel and his team throughout his life, because MC Patel, Dr. MC Patel, all of us know that he is definitely a right person to be today. Thank you all once again. Thank you.
Thank you, madam, for sparing time to bless us. Of course, you are always with us in any of our academic activity. Thank you very much.
Thank you.
Thank you, ma'am. I request Dr. Rekha ma'am to please introduce our next guest of honor, Professor Aparna Borkar ma'am.
Thank you. Please, can I have Madam CV? Thank you, Professor Aparna madam.
Thank you, ma'am.
Yeah, for consenting to be the guest of honor today. That itself is a pleasure and privilege. Madam is a professor and COVID MS at new upcoming medical college in Vidarbha region. Has been teaching for more than. Dr. Neetika, can you mute yourself? Yeah. Thank you. There's a lot of disturbance. Teaching experience of 25 years as registrar and the government medical colleges, Medical Council of India approved inspector, Medical Council of India as approved for start of 11 seat year. Also the recognition of 2 seats, member of MET committee, ethical committee and curriculum committee. Madam, you are a person with rich CV from Akola. We would like to hear from you. Dr. Aparna madam.
Yes, ma'am. Good evening, everybody.
Yeah.
Yeah. First of all, hats off to Dr. MC Patel, sir. I admire his perseverance and discipline. He's arranging these webinars since last 3 years. Now this is the 198th webinar year. And I congratulate all the committee members, Dr. Asha Jain madam also, for arranging such nice webinars. And the topics are also very nice. First of all, the first topic, which is the abruptio placentii topic, we are very happy to have our faculty, Dr. Neetika Raghuvanshi ma'am, who is going to give a talk. She's from Akola, GMC Akola. She's going to present on the abruptio placentii. And we are working in a tertiary care center. We know very well how many cases regularly we come across with abruptio placentii. The second topic, which is the MTP Act. This is a very happening topic nowadays because so many patients nowadays are coming to government colleges for termination of pregnancy, especially for medical board and termination of pregnancy. Nowadays, we are also seeing that many fetal anomalies have been detected, and every week we are having a patient for the medical board. Well, I don't know whether this is a good point or a bad point for that. But thank you, sir, again, once again, for inviting me on this webinar as a guest of honor. Thank you so much, sir.
Thank you. Thank you, madam, for sparing time to bless us. Thank you.
Thank you, madam.
Thank you.
Dr. Rekha, if you would take the next one as well.
Yeah. Thank you. Namaste, Dr. Sunil Shah, sir. Thanks for being here. I would like to have CV of sir to be displayed. Dr. Sunil Shah, sir. Sir is a senior consultant obstetrics gynecology from Baramati. If I can have sir's CV, that would be great.
Ma'am, only these things I have received.
Okay, fine. Sir Sunil Shah, sir, we can see you there. Can you proceed? We would like to hear from you, sir.
Yeah, it is a good initiation by Dr. M.K. Patel, sir.
We would like to see you, sir. Make your
No,
switch
my
on.
video
your
is not on.
All right, fine, sir. Please proceed.
Welcome, sir.
Thank you, sir. Thank you, sir.
Yeah, please proceed, sir.
Yeah, we know Dr. M.K. Patel, sir, since last 10 to 15 years. He is very active member of FOXY, and he is very enthusiastic and encouraging to the young junior members and senior colleagues also. He has thorough knowledge of medical legal problems in medical practice also, and he is now conducting all these CMEs for giving and providing the knowledge to the new PG students, to newcomers, and all these CMEs are very well worth and well educated to the knowledgeable to the students and also junior and senior colleagues also. I thank you.
Sunil
for
Shah, sir,
inviting me
voice
as
has
chief guest.
disappeared, sir.
Thank
Yeah,
you.
I thank you him for
Your
inviting
voice
me
has
as chief guest for
disappeared.
this
No, we
webinar.
can hear. We
Yes.
can hear.
I think
Welcome,
there is some
welcome.
problem with sir's video and
No.
internet connection.
No,
Sir,
no,
may we
no issue,
proceed to the next
but
one?
he is audible. He is audible.
Yeah.
No issue. Yes.
He's
Sunil sir.
quite
Patel, sir,
audible.
we can't hear you.
Dr. Asha, we can hear Dr. Patel as well as Dr. Sunil Shah properly. Dr. Sunil had switched
Can't
off.
hear anyone. Tirth?
Yeah. Sir MC Patel, sir, please
Tirth?
proceed.
Yes,
Okay.
ma'am. Ma'am,
Sir,
it is
thank
audible.
you. Yes, Sunil sir. Sunil sir. So
Yes,
thank
sir.
you. Yes. Yes,
Sunil,
sir.
sir, we can hear you. If you don't mind, you can proceed so that we
Yes, you
listen to
can
you.
continue. No issue. Video is not working, but your audio is working and we can hear you.
Okay. Thank you for inviting me as a chief guest for this webinar. Thanks again, Dr. M.K. Patel, sir, and the team who have arranged, and Karuna also, who has arranged this webinar for education purpose. Thank you.
Thank you. Thank you, Sunil sir, for sparing time. You are always with us in any of our academic activity to encourage us. Thank you. Thank you, sir. Yes,
Yeah.
Rekha.
Yes, Mr. Teeth, can we have the CV of the third guest of honor, that is Dr. Ajay Rao Vasu, sir? Dr. Ajay Rao Vasu, sir, CV. Yeah, thank you so much. Thank you, Dr. Asha. Thank you, MC Patel, sir. I proceed here inviting Dr. Ajay Rao, sir, as a guest of honor for our program today. Sir is practicing as a gynecologist for past 22 years in Chikali. He's an ex-medical officer, General Hospital of Kargaon. He's an ex-IMA president of Chikali. Sir is a member of many important international bodies. He has had two paper presentations in international conference, one paper presentation in national, and 2 paper presentation in state conferences. Sir appears to be very much interested in colposcopy, and so he has conducted and trained himself in many of the programs. Thank you, madam. Yeah, sir, please. We would like to hear from you and take your advice.
Thank you, madam, for a nice introduction. I would say to thank you for MC Patel sir and Asha madam for inviting me as a guest of honor. Really, today's topic is very important for daily practices, Abruzzo Placenti and MTP Amendment Acts. Really, that will help us in daily practice. Thank you, madam.
Thank you. Thank you, Ajavraj sir, for sparing time
Thank you, sir.
to
Thank
bless the webinar. And thank you.
Thank you, sir. Thank you, Vasu sir. Something had gone wrong with my audio. I couldn't hear anything. So now sir, if you allow, we will start with the
Oh,
scientific.
yes. Oh, yes. Oh, yes.
So thank you all the dignitaries for this inaugural session and all your blessing. Now I would also thank Tirth Shah and Corona Remedies for being our academic partners. And now I ask Dr. Rekha Rajendra Kumar ma'am to please introduce the chairpersons of the first session.
Yeah, thank you. CV of chairpersons, Dr. Surekha. Can I have CV of Dr. Surekha?
Ma'am, only these things I have received.
Okay. Dr. Surekha Thaide is a good friend of ours, and she's a past president of Deoli Savangi Society. She is also the chairperson of Clinical Research Committee, FOXY. In a few days back, we all met in Kolkata, MCM, and that time we could hear the work Dr. Surekha Thaide has done as a chairperson of Clinical Research Committee. Lot of work has and the effort has gone behind your work, and your presentation was quite rich, Dr. Surekha. I'm extremely sorry that I don't have your CV here to present it in a very professional way, but we would like to hear, and we are very happy that you have agreed to be the chairperson for today's session. Welcome you, Dr. Surekha. We heartily welcome you here.
Thank you, Dr. Rekha. That is so kind of you.
Yeah, thank you. I have the CV of Dr. Sheetal Bhandari, Mr. Tirth, the second chairperson. Yeah, thank you. Dr. Sheetal Bhandari is the president of Pussad Obstetrics and Gynec Society, and the present president. She was the ex-secretary of the same society around 2 years ago. She's practicing in our field in Pussad for the past 20 years. Director of Devashish Bhandari Hospital, Pussad. Welcome, Sheetal Madam. We are happy that you have accepted our invitation as chairperson. We would like you to be the chairperson here. And I would like to have the CV of the third chairperson, that is Dr. Rajesh Kokre, sir. Yeah, thank you. Dr. Rajesh Kokre, sir, is MBBS DGO and Diploma in Family Planning. Sir is right now working in the Government Medical College of Baramati as a senior consultant. His interest in the obstetric gynec field is high-risk pregnancy as well as infertility. Thank you, all the three chairpersons, Dr. Surekha, Dr. Sheetal, and Dr. Rajesh. I request.
Thank you for inviting us.
Thank you, sir. I request the chairpersons to chair the session, take it forward, introduce the speaker and the talk. Thank you. The chair is yours.
Thank you so very much.
Thank you, ma'am. Thank you, ma'am.
Am I audible?
Yes, yes, you are audible, Surekha.
Thank you, sir. Sorry for not opening the video.
No issue.
I am in the OT, sir. Thank you very much. And I would like to thank Dr. MC Patel, sir, for inviting us for chairing this session. It's very, very important webinar. And we all know that this Happy Learning webinar series is so very popular. And sir has been consistently and dedicatedly, educating everybody, the Foxians, for last 3 or 4 years. And we all know him as a great Foxian working for the organization for many, many years. Sir, we are all indebted to you. You have been supporting us, I can think. So all the best for all your endeavors, sir. And
Thank
we
you.
hope to see you
Thank
at
you.
the highest
Thank
position
you.
of seat.
Thank
Thank you very
you.
much. And I
Thank
would like to introduce, to take the opportunity to introduce our first speaker. Can I have the CV, please? The topic is really very interesting, as Dr. Aparna has said. Abruptio placentis very commonly we encounter in medical institutions, and it would be nice to hear from the speaker. Can we have CV, please? On the slideshow.
Yeah, Dr. Suresh.
Is it visible?
She is MBBS from the Netaji Subhash Chandra Basu College, MS from MGM, DNP and MNMS, received Dr. Reddy's board medal, and she did various trainings in colposcopy, FCCA sports and obstetric critical care, an associate professor and unit head at GMC, Akola, which is approved teacher, NMC accredited speaker, presented various posters and papers, national and regional conferences, and she has various papers and case books published as well in reputed journals. So we are happy to have Dr. Nitika present to us on this very important topic of abruptio placentis. Welcome you, and the floor is yours.
Thank you very much, madam. Am I audible?
Yeah, you are audible.
Yeah. Thank you very much, madam. Good evening to all esteemed members, and good evening to the guest of honor, chairpersons, Dr. MC Patel sir and Dr. Asha Jain madam, for giving me this opportunity to speak on such an important topic of abruptio placentis. At the outset, I will also like to wish MC Patel sir best wishes for his forthcoming presidential elections, as well as Asha madam also. And we are here to support you, sir and madam, and we want to see you at a higher positions, and in the same way keep on educating us and supporting us.
Thank you.
So now I'll start with my presentation. Slides are visible?
Yes. We can see your first slide.
Okay.
The faculty can mute yourself. Great. Dr. Sandhya and Dr. Aishwarya.
Okay. So to start with abruptio placentis, it's an antepartum hemorrhage referring to premature separation of a normally implanted placenta from the uterus prior to delivery of the fetus, but after 24 weeks of gestation. If you see the incidence, it is 1 in 100 deliveries. 30% of all APH are due to abruption. Majority of the cases, that is 60%, they occur in third trimester. Bleeding is mostly maternal, but sometimes placental tear may cause a fetal bleeding. It is significant cause of perinatal mortality, that is contributing around 15 to 20%. Maternal mortality is seen in around 2 to 5% cases. What are the risk factors for abruptio placentis? If there is a prior abruption, the woman is again at a higher risk. Increasing parity in maternal age contribute to it. Maternal substance abuse like cigarette smoking and cocaine. Maternal diseases like hypertension, hypothyroidism, asthma, and premature rupture of membrane. Risk factors for placental abruption to add to the list. There is rapid uterine decompression following the delivery, or polyhydramnios, uterine, placental, and fetal factors like uterine anomalies, torsion, synecdoche, fibroids, cesarean scar site implantation of placenta, abnormal placental formation, short cord, chronic ischemia. I think somebody is not muted. Hello.
Dr.
Tirth, please mute everybody except speaker.
Okay, sir. Okay.
Thank you. To add to the list, folic acid deficiency, supine hypotension syndrome. Here there is congestion of vessels at the base of the placenta resulting into disruption, thrombo.
Nikita ma'am, please unmute yourself.
Thank you. Somehow the slides are not working.
Yes, now you are audible.
Audible? Yeah, but my slides are not changing. Something went wrong. Yeah. Thrombophilia, hyperhomocystinemia, trauma due to external cephalic version, road traffic accidents, blunt trauma, or during the amniocentesis procedure. Now, pathophysiology, abnormal early development of spiral arteries resulting into the residual necrosis, inflammation, infarction, and vascular disruption that ultimately causes the thrombin release, and it acts as a direct uterotonic, enhances the action of matrix metalloprotease, upregulates the apoptosis gene, it increases the expression of inflammatory cytokine, triggers the coagulation cascades, and it causes the withdrawal of progesterone. The clinical manifestation depends on many factors like nature of abruption, acute versus chronic, type of abruption like concealed versus revealed, severity or grade of abruption extending from grade 0 to grade 3, and location of abruption like retroplacental, subchorionic, or preplacental. So in few slides, we are going to see how it is going to affect the presentation of abruption. So if it is nature acute versus chronic, if you see the acute variety, the onset is sudden. The causes here are blunt trauma, sudden uterine decompression following the delivery of a twin or in polyhydramnios, road traffic accident. Here the placenta is absolutely normal. There is no pathology with the placenta. Hence the fetus is not affected. If you see the chronic variety, the duration is long. The maternal substance abuse is seen. Maternal diseases are associated. Uterine, placental, and fetal factors are the main culprit. Folate deficiency and hyperhomocystinemia. Chronic placental ischemia is the main culprit over here, and the placental pathology is the main cause. Here, the evidence of placental separation may be seen in ultrasound since early, and it affects the fetal growth. If you see the revealed versus concealed variety, the symptoms in revealed are abdominal discomfort followed by vaginal bleeding. The character of bleeding will be continuous dark color blood. The general condition of the patient will be proportionate to the amount of blood loss. The uterine height will also be proportionate to gestational age. The feel of uterus will be normal with minimal tenderness, and the fetal parts will be easily identified. Urine output will be usually normal. In concealed variety, if you see, the symptoms will be like an acute abdomen. There will be intense pain followed by slight vaginal bleeding or no bleeding at all. The character of bleeding, if at all present, will be only blood-stained serous fluid. General condition will be disproportionate. The patient will, though showing no bleeding, will be in extreme shock. The uterine height is also disproportionately enlarged. The feel of uterus will be tense, tender, and rigid. The fetal parts are difficult to palpate. Fetal heart sounds are mostly absent, and the urine output is diminished. Something working. Not able to change my slide. Yeah. If you see the grades extend from grade 0 to grade 3. In grade 0, the disease is very minimal. So here it is asymptomatic almost, and the diagnosis is retrospective. There are no signs and symptoms. fetus and placenta when it is delivered, then subsequently you diagnose that there is retroplacental clot and the bleeding is always less than 150 cc. If you see grade 1, there are again no signs of maternal or fetal distress, but mild symptoms may be present in the form of minimum bleeding or minimal pain. There are no signs of maternal and fetal distress, but the blood loss is around 150 to 200 cc. In grade 2, though there are no maternal shock sign, but the fetal distress may be present. Moderate degree of symptoms seen with the vaginal bleeding, moderate amount of with tenderness is also present and increased uterine activity. Though there is no maternal shock, the signs of fetal distress may be present. CTG will show deceleration, so sinusoidal patterns, and the uterine activity is increased. The loss is around 500 cc. In grade 3, you get maternal shock associated with fetal death, obvious severe symptoms with vaginal bleeding, woody hard uterus, significant uterine tenderness, maternal shock with no fetal heart sounds. In subtype A, there is no coagulopathy, but in subtype B, the coagulopathy is also established and the loss is more than 500 cc always. How does the location affect the abruption? In the first slide, you can see here the bleeding is pre-placental. Here the bleeding is in between the amnion and chorion, and this is known as subamniotic variety. And here the prognosis is very good. If you see the second variety, that is subchorionic abruption, here the bleeding is in between the placenta and the membranes. It is also known as marginal variety. You can see the bleeding over here, and the prognosis is moderate. The third variety is known as retroplacental hemorrhage. The bleeding is in between the placenta and the myometrium, and this carries the worst prognosis. The diagnosis of placental abruption is primarily clinical, but it is supported by radiological evidence. Early hemorrhage is typically hyperechoic or isoechoic. Here you can see this is hyperechoic and this is isoechoic. And this is usually misinterpreted as thick placenta or fibroid and hence sometimes missed. While if you see in the late first week or second week, it is seen as either hypoechoic or sonolucent because of resolving hematomas. So this is how with the time the presentation changes. Now there are certain laboratory findings or tests which supports the prediction of abruption. Close association is seen with the abnormal maternal serum aneuploidy markers in early pregnancy. If you get an elevated unexplained maternal serum alpha fetoprotein or human chorionic gonadotropin, you can have a suspicion for the same. If there is decrease in PAPA, unconjugated estriol or inhibin, again we can have suspicion. Low fetal fraction of on first trimester cell-free DNA aneuploidy screening is also found to be associated with high grade of abruption association. What are the maternal complications? Maternal hemorrhage. It can present in the form of concealed hemorrhage, can be a revealed one. There could be an intraperitoneal bleeding. Once you're opening in cesarean, we get a blood stain like ascitic fluid. There could be broad ligament hematoma, covaliar uterus, or blood in the amniotic fluid. Consumptive coagulopathy, because of release of thromboplastin, it results into activating the coagulation cascade, and then consumptive coagulopathy starts. Shock, which may be disproportionate to the amount of blood loss, especially in cases of concealed variety. Amniotic fluid embolism, end organ damage, anuria, serotonin from the drainage uterine muscles result into renal ischemia, causing the acute tubular necrosis and ultimately renal failure. Feto-maternal hemorrhage may be requiring higher dose of NTD because of excessive feto-maternal leak. Postpartum hemorrhage because of uterine atony and increased serum FDP. Puerperal sepsis, Sheehan syndrome, peripartum hysterectomy, and ultimately we may lose the patient. That is maternal mortality. Fetal complications, fetal growth restriction, oligohydramnios, prematurity, hypoxemia, and stillbirth. Management of abruption. So initially we must know what we are dealing with. So we have to evaluate the patient. So the laboratory assessment to be done are hemoglobin, hematocrit, platelet count, fibrinogen level, FDP, PT-INR, PTT, KFT, LFT, and ABG. Now there is a DIC profile that we must know. There are some investigations which come under this line. So fibrinogen, the normal range is around 150 to 600 milligram per deciliter. It decreases in cases of abruptio placentae. FDP, PT, and PTT plus D-dimer. All these are going to increase in cases of DIC. If you see the platelet count, again it decreases in DIC. There is a DIC score because there is sometimes dilemma whether the patient is in DIC or not. So how to know about this? So all those parameters which we have seen previously have been given some points and we can calculate the score. So if INR is less than 1.3, it has not been scored. But if it is in between 1.3 to 7, the score 1 is given. And if it is more than 1.7, then it is score 2. PD prolongation, if it is less than 3 seconds, no scoring. If it is in between 3 to 6, 1 point. And if it is more than 6, then 2 points is assigned. Fibrinogen level, if it is more than 100 milligram per deciliter, it is fine. If it is less than 100, then it is 1 point which is given. D-dimer, less than 400 nanogram per deciliter, no point is assigned. But if it is in between 400 to 4,000, 2 points. And if it is more than 4,000, then 3 points are given. Same, the platelet count, if it is more than 1 lakh, it is fine. If it is in between 50 to 1 lakh, 50,000 to 1 lakh, then it is 1 point. If it is less than 50,000, then 2 points. We have to sum all these points. And if the point is coming more than 5 or equal to 5, then patient is positive for DIC. But if the point is less than 5, you can consider it negative. But sometimes these patients are in non-overt DIC because they'll end up in overt DIC after few hours. So you have to repeat the test after 12 to 24 hours if you have a high suspicion that the patient can go into DIC. Fetal investigations. Whenever possible, CTG monitoring should be performed. The knowledge of fetal condition will influence the timing and the mode of delivery. In extremely preterm APH, less than 26 weeks, active obstetric intervention is not in the interest of fetus. So sometimes CTG can be missed or it cannot be admitted. The management of abruption depends on severity of abruption, gestational age, fetal status, and associated maternal complications. Now, when you are managing the patient of abruption, the first and the foremost thing is that you have to resuscitate the woman by appropriate IV access to large bore cannulas to be placed 18 gauze or more. Continuous maternal hemodynamic monitoring should be done, especially CVP monitoring if patient is in shock. IV crystal resuscitation is to be started. Blood loss quantification is must. Availability of blood and blood products should be done. Continuous fetal monitoring. Availability of equipped operation theater and experienced surgeon. Communication, written and explain high-risk consent with relatives is must. Communication with anesthetist, neonatal resuscitation unit, and pediatrician should also be available. What are the guidelines for the abruption management? APH associated with maternal or fetal compromise is always an obstetric emergency. If fetus is compromised or mother is compromised, cesarean section is the appropriate method of delivery. In fetal death, vaginal birth is recommended, provided maternal condition is satisfactory and woman is in established labor, or else cesarean birth is considered. The optimum time of delivery for unexplained APH and no maternal or no fetal compromise is not established. In women presenting with APH before 37 weeks, no maternal or fetal compromise and bleeding settled, there is no evidence to support the elective premature delivery. After 37 weeks, differentiate between excessive show and APH. In cases of minor APH, induction of labor with aim of achieving vaginal delivery should be considered. What about the expectant management in abruption? Expectant management in cases of abruption is an exception and not the rule. Who are the candidates? Those which show low grade of abruption or chronic abruption. Those who are remote from the term, if the fetus is reassuring, and the patient is already kept under observation for 24 to 48 hours and the abruption is not increasing in size. The use of steroids can be done during this period for lung maturation. If you consider that conservation is planned, tocolysis can be used with MgSO4, which gives an added advantage with neuroprotection. Now, if you are seeing a term pregnancy or a near-term pregnancy and fetus is alive, then go for CTG monitoring, and if you see that the fetal heart sounds are reassuring, consider vaginal delivery. If you see that there is a contraindication to vaginal delivery or the fetus is non-reassuring or the mother is unstable, then consider cesarean delivery. If the fetus is dead, in that condition, vaginal delivery is considered. But anytime you see that the patient is failure to progress or the mother becomes unstable, then immediately turn it into cesarean delivery. If there is any contraindication to vaginal delivery, proceed to cesarean delivery. What if when we are dealing with a preterm abruption, if the fetus is alive and the gestation age is around 24 weeks, then you have to assess the mother. If mother is unstable, deliver immediately. If mother is stable, can consider the conservative management. If the fetus is more than 24 weeks, then you have to assess both maternal and fetal condition. If both of them are non-reassuring, deliver. If both of them are reassuring, then manage conservatively, give steroids, tocolytics, closely monitor, keep on doing ultrasounds for their growth and evaluation, and deliver at term. If the fetus is dead, then there is no question, you have to deliver. When the mother is in shock, that is maternal shock, diffuse or massive hemorrhage, if she is in early labor, she is primi gravida, Bishop's is not favoring, the cervix is closed, means either there is an active emergency or the time duration taken will be long. In either condition, you have to consider for cesarean delivery. If the woman is in labor and she is progressing well, she is in advanced dilatation, multipara, and you think that the prompt vaginal delivery is possible, go with amniotomy, analgesics, oxytocin to increase the labor pains, vacuum extraction, cut down the second stage of labor, manual placental removal, uterine exploration with removal of clots, uterotonic following the delivery, and hemodynamic monitoring, because these patients end up with PPH. If the bleeding persists, you can go for conservative surgical management. If not working, then hysterectomy can be given to these cases. What are the indications for vaginal delivery in abruption? Low-grade abruption, reassuring fetal heart sounds, facility for electronic fetal monitoring, when you can anticipate a quick vaginal delivery, when the mother is stable with low-grade abruption and the dead fetus. Cesarean section is indicated when there is severe abruption with live fetus, any degree of abruption, but fetus is in distress. Vaginal delivery is remote with increasing abruption. Amniotomy is not possible because of unfavorable cervix, and unstable mother with severe abruption and dead fetus. Managing the obstetric hemorrhage now. Prefer general anesthesia because these patients are very labile and they are usually in shock. Prophylaxis of atonic PPH should start promptly. How do we do it? Step 1 is the medical interventions. We all know these oxytocics, that is oxytocin infusion, methargine, carboprost, carbetocin, misoprostol, and tranexamic acid, their doses and how frequently they can be used. If step 1 is not working, proceed to step 2, that is bimanual compression. Here you can see the picture, or aortic compression. If that is also not working, proceed with the transvaginal options, that is uterine packing and uterine balloon tamponade. Packing is not preferred nowadays, but we proceed with this uterine balloon tamponade. Gives an excellent effect. If this is also not doing, then go for compression sutures like B-Lynch, modified B-Lynch, Hemin suture, and Cho sutures. You can also consider conservative surgical management with stepwise uterine revascularization. Go for a uterine artery ligation, you can see over here, or ligation of uterine and ovarian anastomosis, which is seen at this side. Bilateral internal iliac artery ligation can also be done. This is our own patient in which we have proceeded with the internal iliac ligation. If nothing is working, then proceed with the obstetric hysterectomy without wasting the time. Now, what about DIC? The diagnosis and the management of DIC is complex and it is challenging. It is best managed by interprofessional team. Pregnancy-related DIC needs aggressive factor replacement with emphasis on maintaining adequate fibrinogen level. Treat the cause first by delivering the baby. Transfuse FFP 15 ml per kg. Transfuse platelets. Inactive bleeding when the count is less than 50,000 per cubic liter. If there is no bleeding and the count is less than 20,000 per cubic liter, along with the PC. In massive transfusion, keep the ratio of FFP to platelet to PCV as 1:1:1. One fresh blood increases the fibrinogen level by 12.5 milligram per deciliter and platelets by 10,000 to 15,000 per cubic. How to manage the hemorrhagic shock? Here, BP may not be the correct guide to assess the shock because these patients are hypertensive. They are known cases of PIH. There may be vasospasm because of shock. So the best method to monitor the patient is CVP, and that is to be maintained at 10 centimeter of water. Keep the hematocrit to 30% and urine output to be 30 ml per hour. This is 30 rule of Pritchard. Hemorrhagic shock, which fluid to be used? So restore the circulating volume by using crystalloid till the time you are available with blood and blood products. Colloids like Hemaxil, they are isoosmotic with plasma and they promote the osmotic diuresis and do not interfere with the coagulation. 6 liters of crystalloids are needed for 1 liter of plasma loss. That one should remember when we are resuscitating the patient. Oxygenate at the rate of 6 to 8 liters per minute. Keep an aim of keeping the blood pressure more than 90 millimeters of mercury, mean arterial pressure more than 60 millimeters of mercury, CVP in a range of 12 to 15 centimeters of water, pulmonary capillary wedge pressure at 14 to 18 millimeters of water, mercury. SpO to be more than 92%. What about ABG? PaO2 should be in between 80 to 100 millimeters of mercury, PaCO2 in between 30 to 35 millimeters of mercury, and pH should be more than 7.35. Some patient may require endotracheal intubation and mechanical ventilation. When they are throwing a respiratory rate of more than 40 per minute, there is severe hypoxemia and altered sensory. Corticosteroids do play a very important role in these patients. They improve the regional blood flow, reverses the metabolic acidosis, positive inotropic effect, and improves the cardiac efficiency. Vasopressors like dobutamine, norepinephrine, adrenaline, they have both inotropic as well as vasoconstrictive effect, but dopamine causes arrhythmia, so it is not preferred. A word about amniotic fluid embolism. It is also known as anaphylactic syndrome of pregnancy. The pathophysiology of amniotic fluid embolism is anaphylactic reaction to the amniotic fluid getting into the maternal circulation. It can present in phase 1 with respiratory and circulatory disorder, in phase 2 with coagulation disturbances of maternal hemostasis, phase 3 acute renal failure and ARDS leading to cardiopulmonary collapse. 4 criteria must be present to make the diagnosis. First is acute hypotension or cardiac arrest, acute hypoxemia, coagulopathy, and all these events are occurring during labor, cesarean, or within 30 minutes postpartum with no other explanation. So there are some dilemma in diagnosing of amniotic fluid embolism in cases of abruption. Now, how do we manage the case of amniotic fluid embolism? All the things which we have seen previously are to be once again repeated. That is rapid correction of hemodynamic instability, oxygenation, control of airway by intubation and positive pressure ventilation, fluid resuscitation with crystalloid colloids and blood products, correcting the coagulopathy by FFP, platelets, and PCV. And if fibrinogen level is less than 100 milligram per deciliter, give cryoprecipitate, each unit of which increases the fibrinogen level by 10 milligram per deciliter. Now, the take-home message: premature separation of normally implanted placenta after 20 weeks of gestation is an abruptio placentae. It represents 30% of APH, mostly occurring in third trimester. Thrombin release acts as direct uterotonic and it triggers the coagulation cascade. Clinical manifestation depends on nature, type, severity, and location of bleeding. Subamniotic abruption has better prognosis, while retroplacental has worse prognosis. Close association is seen between abnormal maternal serum aneuploidy markers and early pregnancy and abruptio placentae. Maternal complications like hemorrhage, shock, amniotic fluid embolism are causes of maternal mortality. Major cause of perinatal mortality and prematurity and IUGR. BP is not the correct guide to assess the shock. CVP monitoring is ideal. Maternal resuscitation with crystalloid colloids, blood and blood products to be started promptly. Consider corticosteroids and vasopressor also. If fetus or mother is compromised, quick delivery by cesarean section is required. If fetus is dead or FHR is reassuring with stable mother, consider for vaginal birth. Expectant management and abruption is an exception and not the rule. MgSO4 is the best tocolytic agent. When you feel like quitting, think about why you started. Thank you very much for patiently listening.
Hello.
Hello.
I congratulate Dr. Raghuvanshi ma'am for very nicely summarizing the abruptio placenta, the huge topic.
Thank you.
And at the outset, I thank you, Dr. MC Patel sir, for inviting our society for his master class series of webinar for today's very important topic. And thank you, organizers, for giving me a chance to chair the session.
Hello.
Hello. Yes.
Hello, madam.
Hello.
Thank you
Hello,
so
ma'am.
much, ma'am. That was really great.
Madam, can I ask question about abruptio placenta?
Yes, ma'am.
What is this Heman suture, madam? Bilin suture, Heman suture in management she has given.
Hello.
Heman suture. What is this Heman suture? How it is applied, madam?
Hello. Am I audible?
Yes, yes.
Yeah, Beeline suture is when you are taking a cesarean scar and the segment is open. You have to go from the lower segment. Then you have to come back from the posterior surface of the uterus. Again, you have to come and go from the upper segment of the uterus. And then you have to turn the other side. Again, you have to go from the lower segment to the posterior side, come back from the anterior surface from the upper segment, and you have to tie it. So it becomes one complete suture which is going to affect and both the transverse as well as upside down diameter. So it prevents the distension of the uterus, and hence it prevents the atonicity of the uterus. There is modification in V-Lynch also. Sometimes when it is difficult and not possible, and like delivery has done vaginally, and you're opening the patient for putting these sutures because the patient is in excessive PPH. In those situations, the cesarean scar is not there. So in that situation, you can go directly from below and you can take a tie at the fundus. Again, the same thing has been done, just 2 or 3 centimeters away from it. So 2 sutures can be taken going from anterior to posterior directly, and they're coming at fundus and you're tying them. So this gives again the advantage, like most of it like that of V-Lynch. And Cho sutures are spare markings which are to be taken at multiple sites, which is approximating the anterior as well as the posterior wall of the uterus, and they are preventing the collection of the blood inside. So they are giving that advantage. Hemen suture is the circular sutures which are to be taken at the multiple sites.
Okay. Thank you, madam.
Okay.
Thank you so much, Dr. Nitika. That was really great. And now we would nice recollections of my visit to Akola.
Yeah.
So now I think we will start the session. The panel discussion. So, Patel sir, are you
Yes,
there?
ready.
Yes,
Ready,
sir.
but before that,
Thank you,
any
sir.
chairperson has any comment to conclude? Dr. Rajesh is there.
Rajesh sir, would you like to say something? Kokre sir? Sir, I think we start the session.
Okay, no issue, no issue.
So, as you all know, the panel today is on the MTP Act. Dr. MC Patel sir is the expert in the line of fire, and I'm the one in between the questions and sir. So, I would like to introduce sir. Though he's one person who doesn't need an introduction, but it's good to remind ourselves of his achievements. So, sir is a consultant obstetrician, gynecologist, and medical legal counselor. He was VP FOXI 2018, organizing secretary AICOG 2017, chairperson Ethics and Medical Legal Committee FOXI 2011 to 13, honorary secretary SOGO, organizing chairperson MMCon 2018. He was the honorary member of National Inspection and Monitoring Committee, PNDT Act, Government of India. Honorary member State Supervisory Board, PNDT Committee, Gujarat. He was also the president of Ahmedabad Gynec Society, honorary member, National Managing Body, Indian Red Cross Society, national president, National Medical Organization, President IMA Ahmedabad branch, and honorary surgeon, Indian Red Cross Eye Bank. So other than this, he has been consistently doing this series. Also, he has been visiting the Northeast consistently for 21 years. So continuity, consistency, approachability, dependability, these are all the qualities of sir. And I request everyone to support him. That's me, and I've already been introduced. And here is a short video from sir towards his vote appeal.
Shubham karotu kalyanam arogyam sukha sampadam.
Respected seniors and dear colleagues, serving Foxy for years together. On this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
Thank you for that. And here is a short appeal from Sir for his nomination, which will be coming up on the 5th of May, requesting all of you to please nominate him from your respective societies. This is a nomination appeal from me as well. Please do nominate me from your society for Food, Drug and Medical Surgical Equipment Committee. And we proceed. These are our panelists, and we will be introducing each panelist as they come along in the panel. So, sir, as usual, I will ask my first question, that why was the MTP Act needed?
So long back in 1966 and before that, there were so many criminal abortions because medical termination of pregnancy was not legal. So any person doing abortion services or miscarriage, and he and patient herself both were considered guilty. And due to that, patient used to come to go to quack for termination of pregnancy. So government thought for the same, and one committee, Santilal Shah committee, was formed.
Tirth, would you mute people who are not speaking, please? Please mute whoever is not speaking.
So Santilal Shah committee was formed, and in that very committee, 50% members were doctors, and 50% members were influenced by doctors. And you will be happy to know, one representative from Foxy was also there in that very committee. So that very committee came with a draft as far as MTP Act is concerned, and which was enacted in 1971. And after this act enacted in 1971, there were rules and regulations formed in 1975, and this act came into existence for application. After that, in 2003, there was amendment. Then in 2020 and 21, there was amendment. So now it is called MTP Amended Act 2021. So you are muted, Asa. Please unmute.
Yes, sir. So this act basically came to prevent criminal abortions.
Yes, criminal abortion, because they were going in hands of quacks, and many of the patients have lost their life in the process of abortion.
So, sir, now our first panelist is going to be Dr. Deepali Shukla. She is director of Shukla Test Tube Baby Center, and she's the president of Akola Obstetric Gynec Society. She likes drawing, painting, and cooking, other than her various academic performances. So over to you, Deepali ma'am, for your question.
Good evening, everyone. First of all, I am thankful to Dr. MC. Am I audible?
Yes, you are audible.
Good evening, sir. First of all, I am thankful to Dr. MC Patel, sir, Dr. Asha Jain, madam, who involved me in this panel. I take this opportunity to wish both of them all the best for their future endeavors. Sir, wanted to ask you one question. What were the important provisions of this act, and was there any punishment included in this act?
So main provision as far as this MTP Act 1971 is concerned, place and person. Place where MTP can be done and person who can terminate pregnancy. So as far as place is concerned, any government hospital or government aided hospital is the confirmed eligible place for termination of pregnancy, and any clinic which authorized by district level committee or government, then in that very clinic also termination of pregnancy is very legal. As far as person is concerned, any allopathic graduate who is registered in State Medical Council and who has requisite experience in terminating pregnancy, then that person can terminate pregnancy. And as far as experience is concerned, it varies as per gestational age of pregnancy to be terminated. Say, for example, up to 9 weeks of pregnancy, and this came with this amendment in 2021 only, up to 9 weeks of pregnancy, if any person has terminated pregnancy with medical method in 10 cases under supervision, he can terminate pregnancy, provided he should be allopathic graduate and he should have taken training. As far as pregnancy up to 12 weeks is concerned, any person who have terminated pregnancy or assisted rather 25 pregnancy and terminated 5 pregnancy independently in government hospital or any recognized center by government, then he can terminate pregnancy up to 12 weeks of pregnancy. More than 12 weeks of pregnancy, any gynecologist who have degree of postgraduate degree, diploma, DNB can terminate pregnancy for any given gestational age. Any person who is teacher in OBGYN department of medical college, then he is also eligible to terminate pregnancy. Any person who has worked in any OBGYN department in any hospital for 1 year, then he can terminate pregnancy. And person who has done 6-month house surgery in OBGYN practice, he can also terminate pregnancy more than 12 weeks. So these are the criteria as far as person who can terminate pregnancy. And as far as punishment part is concerned, it is very clear. If person is qualified and he has terminated pregnancy at unapproved place is not approved, one condition, and if place is approved, but person is not qualified, or person is not qualified and place is also not approved, then there is a provision of imprisonment from 2 years and which may extend up to 7 years. And as far as some inaccuracy related to records are concerned, then there is a provision of fine of rupees 1,000.
Okay. Thank you.
Yes, next.
So next we have Dr. Varsha Ghate ma'am. She is a practicing obstetrician, gynecologist, a very dear friend of mine, and she loves plantation. She loves chilling with friends, and these days she's very much into swimming. So there she is. And over to you, dear Varsha. She is also the past president of Akula Society. Varsha, are you there? Yeah. Varsha is very much there. If somebody would.
Varsha madam.
Requesting somebody from
Akola.
Akola, please take this.
Sir, I want to be on part of Varsha. How effective was the initial act in its purpose of decreasing unsafe abortions? And
So,
how?
Yes.
Yeah, go ahead.
Hello.
Yes.
Varsha madam is there. She wants somebody should unmute her. She is not able to unmute her.
Okay.
Tirth. please help Dr. Varsha Madam. She is unable to get herself muted. I mean unmuted. She is muted. So has she joined with faculty link or with common link?
I don't know, sir. I'll ask her. I'll ask her.
Oh, yes.
I think we can take another question till then.
Okay. So let us discuss first question, and if Varsha Madam joins, then she will continue with second question. So as far as this initial act which enacted in 1971 and effective from 75, so people or patients were going to quack, and it is almost stopped at a good number, and now people prefer to go to qualified person as far as termination of pregnancy is concerned. And as it is free in government hospital, if patient is not affording, they prefer to go in government hospital. But wherever they go, either in government or in private, if they go with a qualified person, trained person in this termination of pregnancy process, then patients are in safe hand. So it has improved a lot as far as this mortality and morbidity related to abortion services are concerned. Because even today, worldwide, if we go with the statistic, then almost 8 million abortions are going on as far as abortion services are concerned. And out of those, 50% abortions are considered to be unsafe and with unqualified person also. Because in very remote area or remote villages where patient is still illiteracy, that this type of services are available in government hospital free of cost, and they are not aware of this type of services, and still today in very remote area they go to quacks and they ended into some complications also. But with this act, it has become safer as far as termination of pregnancy is concerned. Yes, next. If Varsha Madam has joined. Yes, next.
Sir, how many times was it amended? You have already described. And the last question is, how does it benefit the woman and doctor?
So as far as this MTP Act is concerned, even today and previously also, even today, under Indian Penal Code section 312 to 316, Indian Penal Code 1860, even today, termination of pregnancy is a criminal offense. You will be surprised to know, even today, to terminate pregnancy is criminal offense under section 312 to 316. But when this MTP Act came into existence, under section 3 of MTP Act, it is very specifically mentioned, notwithstanding anything contained in Indian Penal Code or any law time being in force, will not be applicable to registered medical practitioner if pregnancy is terminated in accordance with provision of MTP Act 1971. So it is very clear by that section that if one has terminated pregnancy in accordance with provision of 1971 MTP Act, then he or she will not be triable under section 312 to 316 of IPC. But here word accordance was used. It is very important thing, and you should have terminated pregnancy as per provision of MTP Act 1971. So this is very important thing as far as MTP Act is concerned. So that way it is beneficial to doctor. And when it has become free in government hospital, when all the documents related to patients are kept secret, and when it is safe, then it has become beneficial to women also.
Thank you, sir.
Yes. Yes. Next.
We have Dr. Shalaka Adgaonkar. She is the secretary of Akola Obstetric Gynec Society. And over to you, Dr. Shalaka. She does watercolor painting, sir, but she didn't have time to send it to me. So, Dr. Shalaka, ma'am, over to you.
Yeah, good evening, ma'am and sir.
Yes,
I would
good
like to ask, what are the violations of the act commonly seen in court?
So very common violation of this act is either place is not approved or person is not qualified, and even person is qualified, place is approved, then all the provisions of MTP Act are not honored. Say, for example, consent is to be taken in Form C and consent is not taken. Opinion is to be formed in Form 1 or Form E, as per the case may be, and opinion is not formed. And at the end of month, we have to send all the information related to termination of pregnancy happened in our hospital to appropriate authority, and this information is not sent to appropriate authority well in time. So these are some areas where a violation of Act commonly occur, and in court of law, we are liable for the prosecution. Yes, next.
Next question is, are medical abortions also covered under the Act?
Yes, naturally, it is one of the accepted method of termination of pregnancy. So all the requisites of MTP Act will be applicable even if you are going to terminate pregnancy by medical method.
What are the forms to be filled and the provisions of personal privacy of the lady under the Act?
So as far as forms are concerned, so it is a very long question, but I would like to answer. Let us go like this. There are forms A, B, C, D, 1, 2, 3, and E. So form A is form of application. When we are going to apply for registration of clinic, then we have to apply in form A. Form B, if we are given registration, then it is a certificate of registration, that is form B. And that very certificate we have to display at conspicuous place of our clinic. Form C, that is form of consent, and it is very much mandatory to take consent in form C only. Of course, you can take consent in consent form as usually we take in any other surgery, because in form C it is not informed consent. In form it is simply written that I so and so give my permission to Dr. so and so to terminate my pregnancy. So it is written in form C. It is not informed consent. So as far as termination of pregnancy is concerned, you will go with two consent. One informed consent, as usual we take in any other surgery also, and one consent is form C. Form D, that is opinion from medical board. When patient is referred to medical board for opinion, and when medical board gives opinion, then again one more prescribed form is form D. So they will give opinion in form D. One more form is form E. So if pregnancy is more than 12 weeks and less than 20 weeks, then opinion by two registered medical practitioners is to be formed in form E. Some other forms are form 1, that is opinion up to 20 weeks of pregnancy. So one registered medical practitioner will form opinion in form 1. Form 2. Form 2 is monthly reporting form. At the end of month, we have to report appropriate authority in form 2. But in form 2, we have to go with only statistic. No personal identity of any patient is to be revealed in form 2. Say, for example, in form 2, it is written how many MTP done in last month. Say, for example, in month of March, in your hospital, 20 MTP. So you have to simply mention 20. How many MTP up to 12 weeks? You have to mention figure. Say, for example, 8. More than 12 weeks and less than 20 weeks, more than 20 weeks and less than 24 weeks, more than 24 weeks. You have to go with statistic only. One more column is how many Hindus, how many Muslim, how many Christian. You have to go with statistics only. And all the indications are also given in that very form. You have to give number. How many patients terminated on ground of failure of contraception? You have to mention number. So that way in form 2, you have to go with all this data. Form 3. Form 3 is admission register, or we may call it MTP register also. So all the details of patient is to be filled in form 3, and it is prescribed register with all the columns, name of patient, address, whether married, unmarried, gravid, how many children she have, which method of termination of pregnancy you have adopted, after termination of pregnancy, which method of contraception she has adopted, who has formed opinion, who terminated the pregnancy. So all the details are given in Form 3, that is MTP register, and that register is very secret, and that register is to be kept in custody of head of the institution. So that is Form 3. So these are some forms related to MTP Act. Yes, next. Yes, Asa, you are muted. Please unmute.
Next is Dr. Meena Agrawal. She's done her MBBS DGO from IJMC Nagpur, and she does a lot of dancing, sir.
Very good.
PT, fitness, taking her own Ganesh ji. So over to you, Dr. Meena. Dr. Meena? Dr. Meena?
Hello.
Yes, ma'am. Just a second. Would
Hello,
you
thank
mind
you, madam.
if Dr. Varsha would take the first question and you can take the rest? Because she is able to speak now.
Yeah, yeah. Sure.
Yes, yes, Varsha madam. Welcome.
Yeah, sure, madam.
Varsha? Her audio is not working. I don't know why. What's wrong? Please continue, Dr. Meena.
Okay, madam. Thank you. At the outset, I want to thank Dr. Patel sir and Madam Jain madam for including me as a panelist. And I thankful to my own POG's president, Dr. Sheetal Bhandari also. My first question is who can be shown, it's on privacy, who can be shown the document of the lady who has undergone MTP? Means if anyone comes to for inquiry, then on whose order we can show the documents of that lady?
Yes, appropriate authority of MTP Act, or in some of the state it is called Chief District Medical Officer. He is authorized person to inspect all the registers, all the records related to MTP. And in case of litigation, investigating officer who is investigating that very case, in case of litigation, then he can ask for record of particular patient and we cannot refuse, we have to give. Otherwise, nobody has any power to inspect any record related to that very patient who has undergone MTP.
Okay. And I want to ask, sir, if inquiry comes from police, then
so
is it mandatory
if
to give?
inquiry comes from police in that very condition also, you may ask if there any FIR lodged against that very person, or whatever information you are asking for, and you can ask for copy, or you can ask in a writing requesting to give permission against this FIR lodge for inquiry. Straightway any police comes and asks for record for any patient, you cannot straightway give, and you should not also, because you never know who is that very fellow, whether it is true police or some fake person. So always ask for application, always ask for copy of that FIR under which he is investigating the case.
So, thank you, sir. My second question is MTP form is submitted online in the district authority. Then how privacy is maintained?
So,
what about privacy?
As such, whenever you inform appropriate authority, just I mentioned, it is prescribed form, that is form 2. And in that very form, no personal identity of any patient is to be revealed. Only statistic you have to communicate. So there is no breach of privacy of any patient.
Yes, yes. Yes. Thank you, sir. And
Yes.
nowadays means from the first day, the MTP pills are available over the counter, and it is mandatory to all hospital that report every MTP case. We used to report every case, but what
So
about this counter?
if you can prove that that very pharmacy or person who is not authorized to sell or authorized to advise medicine on OTC, you can inform police. But all the proof should be there to inform police to lodge complaint against that very person. And this could be done not in a personal way, but it should be on association level. Otherwise, it will be difficult for a particular person to face the situation.
Yeah, but it is known, sir. On every counter, it is patient is
Yes,
getting his medicine.
Yes,
But
yes.
nobody is
But-
taking
But if at all some
responsibility of-
complications happens, and if patient lodge complaint, then it will be very difficult for that very person who is working in pharma and who has sold the medicine, because he is not qualified person. His pharmacy is not authorized place to deal with this type of MTP services. So they will be in big trouble. But any association should come forward to deal with this type of situation.
Yes, sir. Thank you, sir. And my next is, if such type of patient who has taken pills from the medical directly and came for evacuation, came with bleeding, then what is the role of gynec person?
So with any complication, any patients come, then we have to treat patient as per complication of pregnancy as we treat, or complication of medicine. But in history, if patient gives history that she took medicine from that very pharmacy, you can write in your history given by patient about taking medical termination or abortion pill from a private privacy or so, pharmacy or so. You can write that. If patient is interested to lodge complaint, then you can inform police. Otherwise, you are not under obligation to inform police in each and every case in this type of situation. When patient comes with complication and patient gives history of taking medicine over the counter. Patient should be willing to lodge complaint.
Okay. Okay, sir. Thank you.
Yes.
So next we have Dr. Lata Agrawal, sir. She is a practicing obstetrician gynecologist in Pusak for the last 26 years. So she loves traveling. She sent me great pictures of her travels, and a lot of them. But these were the two most picturesque that I liked. So over to you, Dr. Lata.
Yes, Lata madam, welcome.
Thank you, sir. Good evening, all. And outset, I thank Dr. Patel, sir, and Dr. Jain, madam, for giving this opportunity. So, my question to you is that in a patient on anomaly scan, a lethal deformity is detected. So, can MTP be done?
Yes, always yes. Under MTP Act, there is a provision as far as indication of MTP is concerned. If there is lethal deformity to a baby, or in one word it is mentioned that any congenital anomaly which is incompatible with life of fetus, then pregnancy can be terminated at any given gestational age.
Yes,
but there is some provision up to 20 weeks with opinion of one registered medical practitioner, more than 20 weeks, less than 24 weeks with opinion of two registered medical practitioners, more than 24 weeks with opinion of medical board. Pregnancy can be terminated in lethal deformity, but this is the provision up to 20 weeks, up to 24 weeks, and more than 24 weeks.
Thank you, sir. Second part of question, for non-lethal anomalies, 27 days. Can we take that? So,
No,
under which
if it is non-lethal anomaly, it means it is correctable one. Say for example, if it is polydactyly, if hair lip, cleft palate, so these are the deformity can be corrected. So they could not be indication for termination of pregnancy.
under which provision and what is the procedure involved, sir, if not so?
So in up to 20 weeks of pregnancy, provision or indications are given. There are 4 indications. One of them is lethal anomaly, or it is written like that: if child is born, then he will be handicapped physically or mentally. So if case is such that if termination is not done, then that very baby will be physically malformed or mentally challenged, then pregnancy can be terminated. But if it is correctable one, then not. More than 20 weeks and less than 24 weeks, if fetal congenital anomaly is incompatible with life, then pregnancy can be terminated. And just I mentioned about more than 24 weeks, opinion from medical board is very much required.
The question from my side that if maternal having severe, then
Your voice is breaking, madam.
If it is for maternal indication, like mother is having severe PIH at 27 weeks, then
we can very well terminate pregnancy under section 5. Under section 5 of MTP Act, it is very specifically mentioned that if it is immediate necessary to save life of patient, pregnancy can be terminated at any given gestational age and even at unapproved place. If place is not approved for MTP and it is indicated to terminate pregnancy to save life of patient, then you can very well terminate pregnancy. It is allowed. Section 5 MTP Act.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you, Dr. Lata ma'am. Now we have Dr. Deepika Devani ma'am. So she is Associate Professor, Department of Gynae, JNMC, Wardha. She is also the President of Deoli Savangi Obstetric Gynec Society. So over to you, Dr. Deepika ma'am. Actually, ma'am, I could not connect with her on phone, so I couldn't ask her hobbies.
Yes,
Deepika
yes,
ma'am,
welcome,
you are there?
welcome, Deepika madam.
Good evening, sir and ma'am. Thank you for the opportunity. So my first question comes to you as who can give consent in a major lady, and do we require the partner's consent?
No, very clear. When patient is major, when patient is mentally sound, she can only give consent for her termination of pregnancy. On her behalf, nobody else can give consent. And very clear thing, no other person consent is required, even spouse. If she is major, if she is mentally sound, she can give consent, and consent given by her is valid consent.
Yes, sir. So my second question is a separate informed consent required along with Form C?
Yes, always yes. Because just I mentioned prior also, in Form C, it is very simply written that I give my permission or consent to terminate my pregnancy. It is not informed consent. And as far as informed consent is concerned, in famous case of Samira Kohli versus Prabha Manchanda, which was decided in 2008 in Supreme Court has come up with guideline. What is the ideal consent in Indian consent? And in that very consent, one criteria for any consent to be valid was informed consent. Consent should be informed one. But for that, you have not to very much. You have to simply visit Foxy website. And on Foxy website, there is title Foxy Uniform Consent. And in that very uniform consent, there are 30 different consent we have prepared. Dr. Dilip Palke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared 30 different consent for cesarean section, for hysterectomy, that is abdominal, vaginal, endoscopy. And in those very 30 consent, we have prepared consent for termination of pregnancy also by medical method, separate consent, by surgical method, separate consent. And in that very consent, we have prepared that consent in two parts. Part one is information. Information, again, we have some 8 subheadings: name of procedure, meaning of procedure, indication, consequences of refusal, probable complication. Complications, say, for example, we have mentioned that there is a possibility of incomplete evacuation and possibility of bleeding, possibility of infection, possibility of complication of anesthesia, possibility of continuation of pregnancy. We have mentioned that also. So everything we have mentioned in that very consent. So you can simply download those consent and you can use in your day-to-day practice. Now it is available in Marathi also. So anybody is interested to have this consent in Marathi or in English, they can contact me. I will send them by WhatsApp. Almost 130 pages are there to cover all those 30 consent. Because in Supreme Court, it was mentioned that consent should be procedure or operation specific. So we have prepared each and every consent for that very surgery or procedure. Yes, next.
Thank you, sir. So, could you provide us with some examples so as to help us to learn to avoid mistakes?
Pardon, I couldn't follow.
Sir, could you provide us with some examples of your cases so as to help us to avoid mistakes?
Yes, yes. So, in one of the cases which happened in city of Ahmedabad only, in 2003, couple had been to gynecologist and termination of pregnancy was done because place was approved, person was qualified, and he went with all this formality of Form C, Form 1, etc. But for any reason, there was quarrel in the family in 2004. So patient lodged a complaint against in-laws that it was forceful abortion against her will without her consent. So doctor was called in court as a expert witness, and court asked record, that is Form C, Form 1, whether patient has given consent or so. But this pregnancy was terminated by medical method, and it was very OPD procedure. So doctor casually answer in court of law, it was OPD case paper patient. I have only examined patient and given medical pills only. So I have not preserve all those records. And you won't believe, court ordered to arrest doctor from the court only. Doctor was put behind bar. After 3 days, there was compromise in the family. Case was withdrawn, and then only doctor could be out of bar. So you cannot afford to simply or casually say like this in court of law, it was OPD patient. Once you have terminated pregnancy, you have to observe all the provisions of MTP Act related to that very gestational age of pregnancy. Form C, Form 1, Form E, whichever is applicable, it should be with you for 5 years. Because any document related to MTP services, you have to preserve all those records for 5 years.
Thank you, sir. So my last question to you, your minimum recommendations to avoid litigations in MTP.
Naturally, person should be qualified, place should be registered for MTP services, and all the provisions related to forms, etc., they should be well filled, and it should be preserved for 5 years, and privacy of patient should be maintained. Because when this act was enacted, 3 words were used: to liberalize provision of MTP Act, to protect registered medical practitioner from purview of IPC, and to keep secret all the document or all the information related to that very patient who is undergoing MTP. So in this act itself, these 3 words were taken into consideration as far as importance is concerned. So to keep secret of all the documents related to that very patient is very much required. So we have to observe all these things, not to end up into litigation.
Thank you so much, sir.
Thank you, sir. Thank you, Dr. Deepika ma'am. And this is Dr. Megha Karnik. She is the secretary of Deoli Society, sir, but she does architectural photography. I know I'll take some time, but see, these are
very good.
Means I actually made a slide of all her photographs because they were so good. Just see. I had never heard of this term, architectural.
Many congratulations, Megha.
You're muted, Dr. Megha.
Yes, please unmute.
Thank you so much, sir. Thank you, ma'am,
Yes,
for
welcome.
your appreciation. And it's a privilege and honor to be here today. So we have few questions for you. So the first thing is that if an MTP is done after 24 weeks and if the baby delivers alive, who has to be given the custody of this born fetus?
So this is very important question, because many a times it may happen that after this abortion, baby may come alive after 24 weeks of pregnancy, and patient or patient party are not ready to take custody. You can shift that patient in NICU. If it is in government hospital, it's fine. But in private hospital, who will bear cost of NICU? So at the time of taking consent, informed consent, you will have to mention that it is likely that baby may come alive. Then we are giving our surety to take custody of that baby if she comes live. So it is very important thing. If patient or patient party are not ready, in spite of giving consent, they are not ready to take custody of baby, then you can inform police also in this situation that this has happened and the party is not ready to take custody of baby.
Okay, sir. So then in this case, should we proceed with the MTP or do we withhold the procedure, sir?
If it is indicated after 24 weeks of pregnancy, say for example, baby is congenitally malformed and it is incompatible with life of fetus, then medical board can opine to terminate pregnancy. If you have opinion from medical board in Form D, you can terminate pregnancy if your center is registered, you are qualified, even at any given gestational age more than 24 weeks of pregnancy. So in this situation, if fetus come alive, then all this problem comes. So just I mentioned, you have to take consent and you will give custody to them. And if they are not willing, you can inform police also.
Yes, sir. Okay, sir. So is if the baby has to be shifted to the NICU, so then who is going to pay for the expenses?
Yeah, you can, but who will pay? Because if it is in government hospital, it's fine. But if it is in private, then at the time of taking consent, if at all, they will have to take custody or baby will have to be shifted in NICU and all the cost will be given by patient and patient party. We have to mention in consent paper also.
Okay, sir. So is there any role of involving the police?
Yes, I mentioned you can inform police.
Okay, sir. So and now that we know that the baby is delivered alive, then is it considered to be a prior feticide now that we are
No, in that very, when we are going to terminate pregnancy more than 24 weeks and we have apprehension that it is all likely that baby may come alive, can we consider feticide before that, just like we do in fetal reduction? So this is gray area. In MTP Act, nowhere it is mentioned, and here comes role of FOXI. All these questions are related, whom custody should be given, whether we can shift in NICU or all this gray area. Can we inform police or can prior feticide is concerned? So here comes a role of FOXI, role of IMA to deal with this type of situation with government to clarify the condition. And that is why in a lighter way, I say that you will have to vote for me and you have to elect me as a president of FOXI. I am going to take all those issues before government and to solve and to make our practice much easier.
Yes, sir.
Yes, next.
Thank you so much, sir.
You're welcome.
So next we have Dr. Pranita Revanwar, who's the secretary of Pusad Obstetric Gynec Society. She does cycling and she is very interested in spirituality and offers a lot of time to that. So over to you, Dr. Pranita. Dr. Pranita?
Is she there? Pranita madam?
Good evening, sir.
Yes, welcome.
My question is a 26-year-old G3P2L2 having 22 weeks pregnancy and her indication is failure of contraception. Can we do MTP?
No, because failure of contraception indication is available up to 20 weeks of pregnancy only. So if pregnancy is more than 20 weeks, then this indication is not available.
Okay. Sir, one more question is there.
Yes.
My patient, 27 weeks with polyhydramnios. about 27 centimeter, and she's complaining of discomfort of breathing. Can we terminate this?
So if pregnancy is more than 24 weeks and if it is indicated to save life of patient, or it is dangerous to the life of patient if we continue pregnancy, then you can terminate pregnancy. But burden of proof is on your shoulder to prove that it was immediate necessary to terminate pregnancy when pregnancy was more than 24 weeks, and you can prove it by documents only. And if you can prove in court of law, if you can justify your action, then you can terminate.
Sir, one more question is there. Today, patient came with 16 weeks, and she has a diaphragmatic hernia and heart shifted to right side, and choroid plexus is there. Can we advise directly to terminate the baby?
Gestational age?
16 weeks.
16 weeks. So with opinion of one registered medical pregnancy, this kind of pregnancy can be terminated, because up to 20 weeks of pregnancy, indication given is if fetus is delivered, he will be physically or mentally handicapped. Then pregnancy can be terminated. So in this diaphragmatic hernia, when heart is shifted to right side or any other side, then it could be troublesome or it will be dangerous to survival of that very fetus. And in this condition, you can terminate.
Sir, one more question. If this,
Dr. Pranita, requesting you please take general questions at the end, because we have an open segment. Let the organized questions be over first.
Okay. We may do like this. So let us complete allotted quota to all the panelists.
Okay, thank you, sir.
We have Dr. Jaya Tulaskar, sir. She is the past secretary of Deoli Savangi Obstetric Gynec Society. She loves to cook. This is a detailed CV, but she loves cooking. Over to you, Dr. Jaya, ma'am.
Yes, Jaya madam. Is she there?
Anybody from Deoli Savangi, if you could take this. I don't see Jaya here. Somebody from Deoli to take this, please.
So anybody can take. Anybody can take.
Yes, sir. A 19-year-old unmarried girl was brought to the hospital in shock by an A&M practicing in periphery who did her criminal abortion at her clinic at 3 months of pregnancy and is accompanied with her parents. Patient on examination was in shock and omentum was hanging through the vagina. What needs to be done?
Naturally, we have to resuscitate patient and we have to deal with that very condition as far as this injury to the intestine, etc. is concerned. We have to involve general surgeon or gastrosurgeon, and we have to deal with all this situation, because this is complication of criminal abortion. But very important question will come. Should we go with informing police or FIR or so? And in this situation, we have to ask to the patient and patient party. If patient is not willing to lodge complaint against that very A&M, then we have not to inform police. But if she is willing, then naturally we have to inform police, and that whole course will be taken by police.
Okay, thank you, sir.
Thank you, sir. Now we have Dr. Suhasini Bhopi, who's the secretary of Pusat Society. She makes eco-friendly Ganesh. Have a darshan, sir.
Very good.
So these are eco-friendly Ganesh. Over to you, Dr. Suhasini, ma'am.
Thank you, sir, at the outset for this opportunity. My question is, 22 years old unmarried girl came with her boyfriend, and she's having 3.5 months of pregnancy, and she's asking for the termination of pregnancy. Can we do it?
Oh, yes. So if center is registered, if person is qualified, one can terminate pregnancy. There is no issue. She is 22 years. So she is major. If she is mentally sound to give consent, then we can terminate pregnancy irrespective of her marital status. Here marital status doesn't matter. But in this type of situation, word of caution, because usual scenario happens afterward. If there is quarrel between that lady or patient and that very boyfriend, and she may lodge complaint against that very boyfriend that now he has given me a promise of marriage, and now he is declined from that promise to be fulfilled. She is not getting married, and now it becomes a case of rape because consent was given against promise. So this type of situation may occur, and police may come to you for inquiry why you didn't inform police. So not to end up into this type of situation, you should go at the time of taking consent with 3 lines, if preferably in handwriting of patients. Otherwise, at the end of these 3 lines, if patient has signed, then it is also enough. 1. It is result of consensual sex. I have no complaint against anybody. I do not want to inform police. Because at that point of time, when patient has come up with her boyfriend to terminate pregnancy, she is very clear that she has no complaint against anybody, including that boy. And she do not want to go, she doesn't want to go to inform police. So if we have taken in writing, then if at all there is something goes wrong in future, and if she lodge complaint against that boy, we will not be held responsible for any reason. So we should be careful when patient is major, when patient is unmarried, and pregnancy is to be terminated.
Sir, on which paper we have to take this consent? Our OPD paper, indoor paper?
Uniform consent. You have, I mentioned prior also, you have to simply visit Foxy website. You have to download Foxy Uniform Consent. In that very consent, if you are going to terminate pregnancy by surgical method, then consent is to be taken by in that surgical method. That is informed consent. If it is medical method, by medical method. So you have to take consent. In that very consent, we have mentioned each and everything. And at the end of that very consent, we have to mention 3 lines. It is a result of consensual sex. I have no complaint against anybody. I do not want to inform police.
Thank you.
Thank you, sir.
Yes,
Thank you,
welcome.
ma'am. Now we have Dr. Aishwarya Paratkar, who is the Additional Secretary of Akola Society. Dr. Aishwarya. She does dancing. She also does plantation. Dr.
Good evening, ma'am.
Aishwarya.
Yes, very good. Welcome, Aishwarya.
Hello.
Yes, welcome.
Yes, Dr. Aishwarya.
Good evening.
Yeah, please proceed.
My question is 29-year-old patient conceived with
ART.
ART. Hello.
Yes, welcome.
29-year-old patient conceived with ART. She is having triplets. Advise fetal reduction. Should center be recognized for MTP?
First thing, it is not MTP because still pregnancy is continued. Yes, from triplet, you are reducing to twins or to singleton, but pregnancy is still continued. So there is no termination of pregnancy. So for that, center need not be registered. Even at unregistered place also, one can go with fetal reduction. But again, I would stress upon informed consent. So in this situation, you have to go with informed consent as far as fetal reduction is concerned.
And which forms are to be filled?
No form, because this is not termination of pregnancy. So no purview, any provision of MTP will come in purview in this type of situation. No form, only informed consent as we take consent in other surgery or other procedure.
Okay. Thank you.
Thank you, sir.
Yes.
Now we have Dr. Sujata Nalat. She is from Akola. She is currently the Joint Secretary of Akola Society. And see her paintings.
Very good. Congratulations.
So over to you, Sujata. Over to you, please.
Yes,
I
Sujata
couldn't
madam.
call her. I can see her, but
Is there? Sujata Nala.
she's there, sir. She's there.
Yes.
Yes, Dr.
Yes,
Sujata.
yes.
Yes,
If the
welcome.
center is registered.
Oh yes, welcome, welcome.
Am I?
Yes,
Yes,
not
you are
now.
audible. You are audible.
Sujata, would you please come closer to
Hello?
the mic and speak? Please come closer to the mic and speak.
Audible? Am I audible now, ma'am?
Yes, yes.
So my question is, center is person is 6 weeks pregnant woman wants MTP, but she is alone. So will you do medical method of MTP if she asks for it?
So as per a termination of pregnancy by medical method, there should not be any problem. Even if she has come alone, she should be major. She should be eligible to give her consent. If she is major, she is more than, mentally sound, then we can very well go with medical termination of pregnancy with consent in Form C and informed consent. But if at all she wants to go for surgical abortion, then if everything goes fine, it's good. But if at all some complications happen, say for example, in one of the cases, the same situation was there and it ended into perforation of uterus during termination of pregnancy by surgical method, and she required blood, she required laparotomy, and in this situation she was alone. So doctor informed relative and this family member, they had been to there, they give consent, they went with all this laparotomy, etc. Patient was saved, but they were had a quarrel with doctor. Why you didn't inform prior this taking this patient for surgical abortion? So as far as surgical method is concerned, there should be somebody with patient who should wait outside operation theater to deal with this type of situation if at all it happens. But at the same time, because again it comes a question of privacy, because as far as MTP services are concerned, we have to take signature of patient only in consent form. No signature of any other person is to be taken in Form C or informed consent in form. Because if patient is minor or mentally challenged, then only consent of guardian is to be taken. Otherwise, only consent of patient is enough. But somebody should be there waiting outside operation theater. And if patient is comfortable to share her information to that very person, we have no objection. We are not sharing information to that third person. So there should be somebody outside operation theater if we are dealing with surgical method of abortion.
So
Yes,
one more
next.
question.
Yes.
If we are in OPD and if guardian or parent of a minor comes to approach us without the patient, just for asking for abortion. So how to entertain, means how to handle this case?
So if patient is
Should we
not
refer
brought,
them?
yeah, if patient is not brought, then you can simply say, I would like to examine patient first. And if she is minor, and if she is pregnant, if pregnancy is to be terminated, I will have to inform police. That you have to explain to the patient relative. If they are comfortable, then we may examine patient, we may terminate pregnancy, but we will have to inform police. and we will have to preserve product of conception in normal saline, and it is to be handed over to the police.
And sir, if patient approaches us, minor patient, and we explain her that I will have to inform police, but she denies, and if she leaves our OPD, we also denies for MTP, and then also should we inform police?
Yes, yes. So under section 19 of POXO Act, which was enacted in 2012, it is very clearly mentioned. Any responsible citizen of India comes to know that she is minor and she is victim of sexual offense, then you are under obligation to inform police or CWC. So even if patient takes further treatment with you for termination or not, but once you came to know that she is minor and she is pregnant, you are under obligation to inform police. Even if patient and willingness of patient to inform police is not taken into consideration. We have to inform police whether patient is willing or not, doesn't matter.
Sir, and if a patient, minor patient, for example, if she comes with her friend, she inquires at the reception and she just go away, then also we are responsible.
So we have not examined that very patient. So we have not confirmed that she is pregnant. So in this situation, we have not to inform.
Okay, sir, that's all from me. And best of luck, sir, to you and Asha Jain ma'am also.
Thank you. So I seek your support.
Yes, sir, sure, sir.
Support as well. Sujata, from your society. Now
Yes,
we are at the end of our session. And any,
Yes,
any
welcome.
question from anyone?
Yes,
Yes,
we have little time. So Monica has joined. So any comments from Monica?
So we've already covered all the topics and most of the points for discussion have been covered.
Yes.
Sir, one more question for me, sir. Patel, sir.
Yes. Yes.
Sir, after abortion, up to 20 weeks, 24 weeks, if fetus is dead, and then can we give it to relatives?
There are two conditions. At the time of taking consent, if he has specified, and if they are willing to dispose of that very fetus with their rituals, then we can very well give the fetus to relative, and we have to take in writing that fetus which was aborted was given to us, because we can give, we cannot deny.
Okay, thank you, sir.
But very interesting question. If they are not willing to get it that fetus disposed, then what should be done? This is a very important question. So here comes role of this Biomedical Waste Disposal Act, and whoever is giving service for biomedical waste disposal in your hospital, you can hand it over that fetus to that person with certificate that baby was aborted in our hospital and this is given for final disposal. So with this certificate, they can go, because many times what happens, if they are going to bury or to have disposal of that very fetus, and some police or some any other person may raise a question. So not to end up into any kind of problem in future for that person or for hospital also, we can issue certificate and then fetus can be disposed of that way.
In which gestational cases, sir?
Yes.
In which gestational age cases?
Any gestational age. If patients relative are ready to take custody of fetus for final rituals, then we have to give them. We cannot deny. But if they are not ready and we have to dispose fetus with biomedical waste disposal service person, then we have to go with all this formality.
Can I ask one question?
Yes.
Is it that we have to take?
Hello.
One by one. Yes. Yes, Nithika madam.
Yeah, so you have given that one situation where the woman was unmarried and she came with the boyfriend for abortion. And if it is a surgical kind of abortion and we have taken her for MTP, and suppose something goes wrong, some complication arises and all, so can that person is able to be informed and that person is valid to give consent? And
What is the age of patient?
Suppose she is major,
She is
22
major.
years.
So if she is major, if she is
Right.
mentally sound, she
Yeah.
can give consent for termination of pregnancy.
Sir, there is not.
I am coming. I am coming to it. Irrespective of her marital status.
Yes.
If any complications happens,
Yeah.
we have to deal that very complication in usual manner. In any other case, if at all we come, say for example, we are doing cesarean section, and if it is tear of uterine artery, what we do? We deal with the situation accordingly.
Right.
And we inform relative if blood is needed, or in few of the cases we have to go for further intervention, or we have to involve our senior colleague. We can do all this in this case also. When she is major, she is mentally sound, then nothing to worry.
Sir, that concept, the information of relative, like we inform the relative what is happening to the patient.
Any person
This
who is accompanying that very patient, and
Yeah.
it is a case of MTP, so
Yes.
we cannot take signature of that very person as a witness, because this information is confidential. If patient is willing to pass on that information to that very person, that is up to her. But as far as our record is concerned, it is very clear that only signature of patient will be there in consent form.
Okay. Sir.
And in form C and in form consent both.
Okay. Thank you.
Sir, there have been situations where the police station does not accept the intimations or information regarding POXO we give regarding whether they say that does not come into our jurisdiction, or whether the patient is from so and so area, so this needs to be sent to that. So in these situations, is there any binding on the police station or the person in charge there to accept our information for the first hand?
So it is very clear. In your hospital, you came to know that she is minor, she is a case of sexual victim, offense. So you have to inform police of your jurisdiction. Whether patient is residing in another jurisdiction, that is up to that police station. They will transfer all the papers of that very patient to that police station. That is not job of doctor to inform police station where patient reside. You have to inform police station of your jurisdiction only. If police station officer is not willing to give acknowledgement of your information, then you can inform higher officer. One thing, you can send it by registry post, you can send it by mail, you can inform on dial 100 number, because 100 number is recorded call. So if you inform on 100, your job is over. But in this situation, even if you can, if you have facility in your mobile, as far as recording is concerned, then you can inform on your mobile also. But in this situation, whenever you inform on number 100 or in on your mobile, you identify the person whom you are giving information, and identify that person, name of that very person, and each police station officer are given buckle number. So you can ask buckle number of that person also. Name so and so, buckle number, time and date. When you inform, on which date you inform is very much important. And wherever you inform police, it should be with acknowledgement, because you should be in a position to prove in court of law, if at all you are facing, that you had informed police. Because if you have not taken acknowledgement, police may go hostile. You never inform, you didn't inform. So it should be with acknowledgement. And these are some ways which we mentioned. One more area, if you are not to do all this thing, you can inform CWC, that is Child Welfare Committee. If patient is minor, you can inform any person of or any member of Child Welfare Committee, and they will take custody of all this case. They will approach police, and police will not deny, because they are taken into consideration seriously. because they are delegated with powers under POCSO Act as far as CWC committee is concerned. So you can inform CWC also.
Sir, and also, is it mandatory to have the examination of a rate 15 performer with us when we are performing an MTP on a minor?
Yes. Whenever any minor is brought to you by relative or by police, if it is by police, then fine. If it is by relative, then first we have to take consent of that very patient. If patient is more than 12 weeks, she can give valid consent for examination. If she is minor, we have to take consent of guardian. If after examination we come to know that she is victim of sexual offense, we have to inform police because she is minor, she is less than 18. If any surgical intervention is required, say for example, she is bleeding and you have to go for stitch, then consent of guardian is required. But person who is guiding that very patient should be major, should be mentally sound, because many times boyfriend with could be with patient and he is also minor, so he cannot give consent for surgical intervention. So in this situation, any person who is guiding the patient and is major and mentally sound can give consent for surgical intervention. After dealing with this emergency, you will inform police.
So then, is it mandatory to send the products for
Yes,
DNA preservation? So
yes, we have to preserve product of conception in saline, and we will inform police that we have terminated pregnancy of this very patient and product of conception is preserved in saline. You please send your representative to collect it. So we have to hand it over to the police. But if police doesn't turn up after 72 hours, this product of conception, even if you have preserved, will not be available for DNA testing as far as quality is concerned. So again, you can inform. If within 24 hours, if police doesn't turn up, then you can inform again. Nobody has come to collect product of conception. Again, we are informing. And even after your information, if they didn't turn up, then you are out of problem. You have to simply inform. What else they have to do, that is up to them. And even as far as information related to patient is concerned, say for example, if it is not MTP, it is simple information. You are informer, you are not complainant. You have to simply inform. Police may insist you to file FIR. So you are not person to file FIR. You have to simply inform. This is to inform that patient so and so, aged this much age, residing at, had been to me on my examination. She was found to be 6 weeks pregnant. That's all. You are not to write. Please do inform. Please do needful. You have to simply inform.
okay. So in case if she is not pregnant and she's only come with a sexual assault,
then also we have
sir, then is it mandatory for us to collect the samples for semen and
no, many a time
if
what
we are
happens,
suspecting a sexual assault, then is it mandatory to have an examination?
Yes,
So-
we have to take concern, we have to examine patient, we have to collect evidences, we have to form opinion, and we have to inform police. And whichever evidences we have collected, we have handed over to the patient, police.
So then at least for every private practitioner, there has to be a kit ready with them for an examination. That is what.
Examination kit should be there. And even if you have no kit, and if you are not in a position to collect all these evidences, once you have examined and once you came to know that patient is victim and patient is minor, you can inform police that I have no facility to collect evidences as far as this examination tool or kits are concerned. So if you permit, can I transfer this patient to government hospital nearby? So, but once you have informed police and if you transfer patient to government hospital, then you are out of problem. But if you do not inform police, if you do not examine, and many times what happens, if you are unable to collect evidences, fine. But if patient is in agony of pain or if she is bleeding heavily, then you have to treat patient. Straightway, without giving any treatment, you cannot refer patient to higher center and informing police. So this is not only to examination, but to treat also in given situation. And you have to offer prophylaxis for HIV also, because you never know, the person who is accused could be HIV positive. So you have to offer in this type of situation HIV prophylaxis also to patient.
Sir,
Thank you
I
so
have
much.
two questions. Sir, please, I have two questions. Sir,
Yes,
if a
welcome.
patient who has a twin gestation and comes after 20 weeks of pregnancy with an anomaly scan suggestive of one fetus having an anomaly, but the other fetus being absolutely normal, and she requests for MTP. Sir, should we?
For MTP or for fetal reduction?
No, sir. After 20 weeks, and she's come for MTP, that my one child is abnormal, the other is normal, but still I do not wish to continue the pregnancy.
Okay.
Can
So if it is more than 20 weeks and less than 24 weeks, if one fetus is congenitally with congenital anomaly which are incompatible with life of that very fetus, but one fetus is normal, so to terminate pregnancy in this type of situation will not be allowed. Yes, if to continue pregnancy, if it is danger to life of patient, then you can terminate pregnancy even if one fetus is normal. But if there is no danger to life of patient to continue pregnancy, then you cannot terminate. And if at all patient is willing, then you can advise them to approach Honorable High Court with writ petition to terminate pregnancy.
Okay, thank you, sir. So my second question is, so when an unmarried but major comes with pregnancy of say 9 weeks or 10 weeks, so we fill that form C. Sir, on that form C, we have various indications of MTP. If we fill the indication as failure of contraception, once a query was raised that indication mentions married woman.
No.
Why
With
have
this
we?
No, Deepika madam. With this amendment which came in 2020 and rules amended in 2021. So previously it was there, failure of contraception was available to married woman and to her spouse. But now word married woman is replaced by any woman and word her spouse is replaced by any person. So any woman, irrespective of her marital status, and with any person, need not to be her husband, they can have indication of failure of contraception up to 20 weeks of pregnancy.
Okay, sir. Thank you so much, sir.
Thank you, sir. I think we are at the end of our questions. Anybody has any other question? If not,
So then we can end with again appeal to endorse our candidature for me, President Foxy, for Asha, the Chairperson, Food, Drugs and Medical Surgical Equipment Committee Foxy. Nomination will be in first week of May and election will be in month of August. For me, it will be from 1st to 10 August. For Asha Madam, from 16 August to 25th of August. So in chairperson election, society will vote. In my election, all the eligible delegate member of Foxy will vote for me. So it is my humble appeal. Consider my seniority, sincerity, dedication, and easily availability to any Foxyan for any odd given situation as far as medical legal crisis is concerned. I humbly appeal to endorse my candidature and to vote for me, to support for me. Thank you very much.
thank you, sir. Thank you.
Yes,
Right
sir.
now is the time for nominations. So please please note down the details and kindly nominate us as soon as you get the mail. It will be a mail to the president and secretary from Foxy. A printout will have to be taken and the details will have to be filled and signed by the president and secretary. Requesting all of you, kindly do support us. I thank all the faculty who have spared their time here. Thank you, Dr. Monica. I thank the senior gynecologists who were here up to now and who participated in this program. I thank Corona Remedies and Teerth for the academic support. Thank you very much. I thank all the delegates who have been listening and because of whom it's worthwhile to make the program. Thank you so much.
One more request to have any comments or any suggestion to make this type of webinar in future more fruitful to our delegates or our member of Foxy. So we are always happy to receive any suggestion or any comments from anybody even after this webinar is over. And again, my sincere thanks to Monica for helping us in our webinar. Whenever Monica is called, Monica is always there to assist us. So thank you, Monica.
Sir, opportunity. It is my pleasure always to be with you, sir. Wishing you all the best for all the future endeavors. Wishing you the best of luck, Asha ma'am, too.
Thank you, dear. Thank you. Thank you so much. Rajesh, sir, would you like to say something?
Sir, thank you so much, sir. We have been always, we are extremely thankful to you for guiding us all the way with your seniority. I wish you for your
Rajesh is good old
present
friend
candidates.
since long. And
Yes.
still, his invitation to visit Baramati is pending.
Yes, sir, definitely.
But he has invited me many times, but for any reason, I couldn't make it out.
Yes, sir.
But let us see.
We can make it this time.
Yes, this time
When
I
you
may
become
visit.
president, you can visit us.
Yes.
After becoming president, you can visit.
Oh, yes. Thank you.
All the
thank
best.
you. Yes, thank you.
Thank you so much. Teerth,
Yes, ma'am.
We can
you may
conclude.
end the session, please. Thank you so
Okay,
much.
okay, sir.
Shubhratri.
Good night, ma'am. Thank you. Thank you, sir. Thank you, Patel, sir. Thank you, Asha.
Okay, okay,
Thank you.
ma'am. With your permission, I am ending this
Oh, yes.
session.
We can conclude.
Okay.